So our next speaker is Dr. Lloyd Sederer. Dr. Sederer is the medical director of the New York State Office of Mental Health. He has a number of different roles. He's an adjunct professor at the Columbia Mailman School of Public Health. He's a medical editor for mental health at the Huffington Post, and he's also a mental health advisor for Turner Broadcasting. He previously served, some of you may know him in his previous role as the Executive Deputy Commissioner for Mental Hygiene Services in New York City. And he has been recognized both for his teaching, receiving Teaching Award from the American Psychiatric Association in 2013, as well as by advocacy organizations, consumer organizations, patient organizations like NAMI, the National Alliance on Mental Illness. Again, his bio is, I think, in your materials. Lloyd is very highly published and has advocated effectively and tirelessly for an area that is really key to, I think, our success and our plan going forward, which is the integration of primary care and mental health. Not as a choice, not as a luxury item, but actually as something that's fundamental and necessary for the success as we've defined it in terms of the triple aim in improving health outcomes. So Lloyd may be a little meshuggah, but he's also a major mensch. Please welcome me in joining Dr. Lloyd Sederer.
Thank you and good morning. Don't ask, don't tell. Don't ask, don't tell. So most of us think, oh, that has to do with the military, with gays in the military. Well, it does, it did, but it also applies to what has been the culture of mental health in primary care settings. Doctors don't ask, patients don't tell. This is not because of bad doctors. I think, these are not knaves. And this is not because of bad patients. But it is certainly not consistent with the call that that the health department has put out, that our whole country has put out, which is that we've got to improve patient care, and here also we have to change the nature of resident training and how people leave and enter their profession and change their profession. But how do we understand this? Don't ask, don't tell. Well, some of it has to do with what's been a long-standing view, which I think is now disproven, but a long-standing view that there's no real science to the delivery of psychiatric care. That you can't respond to depression, for example, in a primary care practice in the same way that you would by detecting and treating hypertension or diabetes or asthma. That psychiatry is this soft field that doesn't lend itself to proper detection, care paths, measurable outcomes, and so forth. So if you start off thinking, well, there's no way to do it, then you're not going to ask. On top of that, imagine, as many primary care doctors I've spoken to also say, well, what happens if the patient starts crying? What the hell do I do then? Or worse, what happens if I ask about mood and whatnot and the patient says, doc, I don't want to live anymore? Your day's ruined, right? Where do you turn? Turn to mental health. Oh, maybe you can get an appointment in 6 weeks if you're lucky, right? If that wasn't enough, you have all, we all live in the context of what costs are, and you say, well, I'm going to do this differently, and then your administrator or your hospital says, well, you can't possibly take on the burden of all of this mental health because there are no procedure payments for it. It's economic suicide to do this. Think of all the indirect care. It's like taking care of children, right? Who's going to pay for calling the school or speaking with the parents? Who's going to pay for the time necessary to talk to this patient? Who's going to pay for the time necessary for a care manager? There's no procedures to pay for this. So if you pile together the fact that there's a view that there's no science, there's no method, God forbid actually if you hear something and you don't know what to do or where to turn, and on top of that it's financial suicide, so that helps explain, at least on the physician side, don't ask. On the patient side, patients are not exactly always knowledgeable that they're sick with a mental disorder, and if they are, there's the shame, the burden, and also the expectation that it's not something necessarily that somebody wants to hear about. So that's been the situation, but fortunately or unfortunately, two things have been game changers that don't permit that to be sustained. The first, which you know perhaps better than me, I'm a psychiatrist, is that your patients with chronic diseases, whether it's a heart disease, a diabetes, Parkinson's, cancer, many of them, 30%, 40%, depends, have co-occurring mental disorders, particularly depression, but not only depression, anxiety disorders, use of too much alcohol and drugs. Their chronic diseases don't get better because they have an undetected mental disorder which impairs their capacity to take care of themselves, to adhere with some sort of self-management, to participate in their treatment. They don't get better. So your patients actually don't get better. You see this, and it results in more tests, more time. You don't escape the problem clinically. But what really always does tip the balance was here in New York State, other states, we looked at who are the highest users, who are the most costly patients in medical care, and it turns out about 80% of them have a co-occurring mental or addictive disorder, and they're the ones that drive, God forbid, potentially preventable readmissions, high use of emergency rooms, longer lengths of stay. So clinical problems and financial problems are the game changers here. And the change underway, which we're doing a workshop on this afternoon, we call it borrowing on techniques, particularly from the University of Washington, is collaborative care. Now, collaborative care is with a capital C and a capital C. It's not collaborative care like you're a nice guy or gal, and I'm a nice person and we're going to collaborate. That's a nice way to participate in medical care, because it doesn't happen. Nor is it detect, screen, and refer. Not only because the resources aren't there, but also because the patients don't go. They just don't go. You give them, so let's say you say, I think you have a depression and I want you to go see this psychiatrist or psychologist down the hall. What happens? They don't go. So, and then you've given them an appointment for 6 weeks. They don't even remember particularly, and if they've got all this mental problems, they're not apt to comply. So the method that we're using here in New York State is called collaborative care. It's highly prescriptive. So of course, everybody resists that because nobody likes being told you have to do this and this and this and not just one of this or one of that. But any type of change requires multiple points of influence all held together at the same time. You don't change things by doing one thing. You change things by doing many things and holding people simultaneously to all of those expectations. So what are the essential elements of collaborative care? Standardized screening. We use the PHQ-2 and 9. It's a depression screen for depression. but it's standardized. It's just like putting a cuff on somebody's arm as a standard medical procedure. Screens screen, they don't diagnose, so the doctor has to make the diagnosis. Then there's guideline-driven stepped care. You know about that, which is if someone has this disorder, here's what you do first, here's how you monitor it. So there is ongoing performance monitoring, outcome monitoring, using this screen, which is also sensitive to change. And then there is psychiatric consultation. Not consultation whereby, if you think you're having trouble, you call some psychiatrist, because that also tends to get wiped away by the demands of the day. It's built in, it's a type of forced rounds weekly with the care manager or primary care physician that looks at your panel of people with these co-occurring conditions and makes suggestions and also expects change. And then there is ongoing performance evaluation, which is what percentage of your patients are being screened? What percentage of your patients are being diagnosed? How many did you get into some type of registry? How many are you sustaining? How many are showing change? All of these elements, highly prescriptive method. We chose this because there's just this incredibly robust evidence that if you do all those things, it will work. And that's what counts. And so there's a lot of resources attached to this. Does mental health go away? No. But maybe you stand a chance to get a mental health appointment because mental health is seen as a precious resource for those people with psychotic conditions, those people who are acutely suicidal, those people with bad addictions, rather than just anybody who's got a depression, you screen and refer. Mental health doesn't go away. Here in New York State, we're more than midway through this hospital medical home project, and a component of it is integration of health and behavioral health. And we picked depression as the index condition to start with. We talked about this. This is standing on the leadership of Nirav Shah, Foster Geston, my former boss, the Commissioner of Mental Health, Mike Hogan. And we said, let's pick depression to begin with. Let's not pile on a whole set of conditions, anxiety and so forth, because you'll never get liftoff if you expect too much. Plus the evidence base and the method was most developed and most associated with success if you pick this. Depression as the most prevalent, most high burden, and most effective. So we're halfway through this. 19 academic medical centers have chosen this here in New York State, 31 practices. And the funding for this that pays, that says, there are indirect costs, is coming from this hospital medical home demonstration and from my agency, Office of Mental Health, which is paying for the technical assistance. But it runs out this December 31st. And we're trying to figure out now how to sustain this, how to sustain financing that pays for indirect care, that result in better clinical outcomes and less costs, and that attends to the workforce issues, that attends to the training, and that reduces the sort of silliness of government where you have to have 2 licenses or 3 licenses, or you have limits on this, or you have to have 2 men's bathrooms next to one another because you got 1 license here and 1 license there. All of this, it's just sort of the goofy accretion of bad government. So this is where we are. This is what collaborative care is, and we're confident that if we do this and if we wind up sustaining it, that clinical care is going to improve and we're going to make a dent in costs. So it's been declared at worldwide now that chronic diseases have now surpassed in public health what used to be the principal causes of morbidity and mortality nationally. So it used to be infectious disease, sanitation, nutrition, globally, not just in underdeveloped countries, but globally. But now chronic diseases. are the principal causes of medical morbidity, mortality, and cost. And when you have chronic disease, chronic physical disease, all the ones I've talked about, hypertension, diabetes, Parkinson's, cancer, stroke, you have as a co-pilot driving the problems, mental disorders, particularly depression. So the impact of chronic disease is what we're all trying to respond to in terms of healthcare, and doing so will require the attention, detection, proper treatment of mental disorders. And I'm grateful to be here today because the medium is the message. It is about the work that is going on here in New York State, and it's the work that's going on between our two agencies that says that if we're going to make a difference clinically and financially, it is by integrating health and mental health. Thank you very much.